for her opening remarks.
Thank you very much, Neil. Just to inform the clinical clerks and interns, you know how long I've known Dr. Neil. Neil, what's your last name again? Binibiro ko lang. I've known Neil since he was a medical student, all right? And I remember very clearly, Neil, baka hindi mo maalala, that I was lecturing on cardiomyopathy and myocarditis. And Neil is the kind of student who sits at the front. Okay? So pag nagtatanong ako, alam ko nakakasagot si Neil. Right? So this is a reminder to our medical students. Lecturers, remember the ones that do well and the ones that do not very well. Okay? Ang hindi natatandaan, medyo yung nasa gitna. Alright? So I don't know which part of the spectrum you want to stay at. But anyway, good morning, everyone. I'd like to, first of all, greet our guests from NKTI, Dr. Glenda Eleanor Pamugas, Dr. Mark Louis Lanting, Dr. Noel Zachary Residoro. We have some fellows from NKTI as well. And when you take a look at the first two rows of this right side, my right, of the room, we have a growing section of nephrology. And I'm very happy about that, okay? Because part of the mission vision of our president for the institution is not just to become the preferred school, it's to become the preferred hospital, the preferred employer, and to become the preferred research center, all right? So as part of the step that we take to become the preferred hospital is expanding our services. So these are exciting times. I'm also very happy to say that our nephrology fellowship training program started since about, I think, 2 years. Is this the second year, right? So it's very exciting that we're seeing our residency training graduates deciding to come back and train in nephrology in this institution. And we're hoping to see that they eventually also decide to stay and practice here and pass on the legacy to our medical students and trainees so that you guys decide to follow in our steps, okay? As we have guests here, we'll be working more closely with people from NKTI. I'd like to invite the clerks and interns at the back. Please pay attention. It's not all the time that we get to invite people with these credentials who will help us in the step towards starting or kick-starting our kidney transplant program. Also, I'd like them to feel that we are a warm community, all right? And the reason why I want to say that is when we were doing accreditation visit for cardiology, for our cardiology fellowship training program, one of the comments of the accreditors was, Ardit, natutuwa ako sa ospital nyo. Kasi yung mga students nyo bumabati sila. Right? He came from UERM. Sabi niya sa UERM, wala silang pakialam. Kaya consultant ka kung sino ka, students just pass you by. And I'd like to keep that tradition within the Lasallian community. All right? So let's give our guests a warm welcome. Let's listen to them. All right? I wish I could say that you guys can get coffee at the back, but I don't think there's any coffee at the back. Definitely there's coffee in Starbucks and McDonald's. All right? So everyone, have a good day. Enjoy this morning's discourse. Pay as much attention as you can. Maybe what you can do when you start getting sleepy, because I know some of you might be from duty, is to stand up and stretch a while. All right? So welcome everyone and have a good morning.
Thank you very much, Dr. Ardit Tan. So before we start the series of our lectures, may I just remind our audience that we will allot an open forum after the discussion of our last speaker. Please keep your questions until our open forum. And now we will proceed with our first lecture about nephrology perspectives in kidney transplantation. Our first speaker, Our first speaker is a graduate of Doctor of Medicine from the University of the East, Ramon Magsaysay Memorial Medical Center. She took her residency training in internal medicine and served as the chief resident in the same institution. She further subspecialized in adult nephrology from the NKTI, where she also served as the chief fellow. She had her master's in healthcare management from UER-MMC. She is a fellow of the Philippine College of Physicians and the Philippine Society of Nephrology. She is the current chair of the Adult Nephrology Division of the NKTI and the current head of the Committee in Transplant Acceptance in the same institution. A multi-awarded and five-star transplant nephrologist, let us all welcome Dr. Glenda Eleanor P. Pamugas.
Pagkahanap ka na yun. Ay sa gabi, wala. Iba na naman.
Good morning, everyone. Good morning po to the administration of Dlsumc Health Sciences Institute. Thank you for the warm welcome for us. I'd just like to say that I've always been, I've always felt very welcome in LaSalle kasi po my kids studied in LaSalle since preschool. So parang part of me feels like a LaSallian myself. I bring them to school, fetch them from school. So parang ganun po. So Dr. Bastona was a fellow at NTTI. Dr. Sheena Diloy also trained in NTTI. And I'm glad to say that we also, as part of the growing family of nephrologists in the LaSalle, that we accepted 2 graduates of your internal medicine program for fellowship this coming year, Dr. Yoshiko Yamko and Dr. Nina Amat. So they're going to start training in March in NKTI. So I was asked today to give you an overview of kidney transplantation. Teaching kidney transplantation has always been my passion and my advocacy since I became consultant at NKTI. So let me give you just a glimpse of our center. This is the National Kidney and Transplant Institute. This is the National Specialty Center for Renal Care and Organ Transplantation. We are one of the 4 specialty hospitals in Quezon City. So together with the Heart Center of the Philippines, the Lung Center of the Philippines, and a little towards the back, the Philippine Children's Medical Center. Okay, so let's talk about kidney transplantation. So, as you know, kidney transplantation is a surgical procedure to replace an irreversibly deceased kidney with a healthy kidney from a donor. I heard that discussion was previously made some years ago about deceased organ donation. So, possible kidney donors to a recipient could be a living donor or a deceased donor. Now, for living donors, they can be related, they can be non-related. When we say related, in the context of organ transplantation, it means someone who's up to the 4th degree of consanguinity. So it could be a sibling, a child, a parent. It could be your aunt or uncle, your first cousin, up to that. Okay, or a niece or a nephew. So that's what we meant by 4th degree of consanguinity. So beyond first cousin, that's already considered a non-related donor. Okay. So deceased donor, on the other hand, is a brain-dead donor. So there are 2 kinds of death, as you know, cardiac death and brain death. In the Philippines, we do not get kidneys from someone who's already cardiac declared to have cardiac death. So only those who have brain death. because we need the organs, the vital organs, to still be functional when we procure them. So I was asked to talk about the steps towards kidney transplantation. So the journey, the surgery itself is like not the end point. It's actually in the middle of the path or the patient's experience towards kidney transplantation. So the steps towards that is for the medical people to evaluate the recipient, and then that is followed by the evaluation of the potential donor, followed by immunologic testing. So when we evaluate the recipient, this has to be somebody whom you know has irreversible kidney disease, irreversible chronic stage 5 disease, someone with end-stage renal disease. And you do medical workup to determine the suitability of the patient for kidney transplantation. Now, one of the hardest steps actually is identifying a donor. In the Philippine community, knowledge about donation is still very limited for most Filipinos. So it's really hard even to convince, even among relatives, to donate a kidney to the patient. Their relative is a patient. So Dr. Residoro will talk about later more about donor evaluation than the process of donation. But part of that is that we do not evaluate just the recipient, but also the donor before we do a transplant. And then we do many types of immunologic tests for the donor and the recipient. Okay, so after all of that, there are some legal processes that the donor and the recipient have to accomplish to get to the transplant. So, as you know, kidney transplantation now is tightly regulated by the Department of Health and the Department of Justice. So, all kidney donor and recipient pairs have to be evaluated by the ethics committee. It used to be before yung non-related, but since 2 years ago, even yung magkamag-anak, even father and son, even child donating to a parent, lahat yan, all of those have to pass through the hospital ethics committee. Though it is easier for them, mas expedited yon because they are related. And then after everything, okay, the kidney transplant surgery, the donor surgery happen, and there's peri-operative care, there's post-operative care, but it doesn't end there. No, we have to have also systems where we also provide long-term care, not just for the kidney transplant recipient, but also for the kidney donor. So, natapos na yung lecture ko. Sorry, nawala. So we've always said, there's no such thing as a perfect kidney transplant candidate. So you have a patient who has stage 5 renal disease who's sick on dialysis. So wala kayong mahahanap na perfect na candidate. So all of these patients have medical problems that you must address, and you must optimize these patients for kidney transplantation. Okay, so when we do evaluation of the transplant candidate, first, as I said, you have to establish that the patient has stage 5 chronic kidney disease. So we can only do a transplant if the patient has an estimated creatinine clearance or GFR, glomerular filtration rate, of less than 20. So even if you know that the patient has CKD, but the GFR is still more than 20, hindi pa yan dapat pag-undergo ng kidney transplantation because the condition of a CKD patient can be optimized. He may live for several years without the need for dialysis or for a kidney transplant, for renal replacement therapy. But if your patient is already a candidate for dialysis, he is also now equally a candidate for kidney transplantation.
So what do we look for? So a patient, before undergoing kidney transplant, must have not any significant cardiac disease. Or kung meron man, kailangan ma-manage yun before doing the surgery. So what do we consider to be active cardiac disease? Angina, arrhythmia, heart failure, symptomatic valvular heart disease. All of these have to be optimally treated before the patient can undergo kidney transplant. So any serious active infection is a contraindication because the patient has to take immunosuppressive medication. So you have to treat these infections before you do the transplant. There must also be absence of severe pulmonary, liver, hematologic, and neurologic disease, which will be affected not just during the surgery, but by the intake of medications after the transplant. And very importantly, dapat walang cancer yung patient. So you must screen for malignancy because if the patient has cancer and if he takes immunosuppression, mas mabilis magpo-progress yung cancer ng patient. And for many types of cancer, even if you do surgery or chemotherapy, there's a waiting period for depending on the cancer type and the stage of the cancer. And it must be ensured na walang recurrence yung cancer. The patient should be cancer-free before you do the kidney transplant. And also very importantly, dapat yung patient has a good compliance with medical treatment. So you can see patients who are pabaya sa dialysis nila or who cannot do self-care. You must assess these patients carefully kung dapat ba silang i-transplant because after the transplant, they have to take medications, they have to be responsible for their health kasi these medications are to be maintained lifetime. On the other hand, ang donors naman have to be near perfect. They have to be healthy to donate. Okay, so Dr. Rosidoro later will talk about the criteria for donation, but let me just say that when we evaluate donors, ang goals natin are two. No? One is to protect the recipient from receiving organs that may transmit disease or otherwise cause damage to the recipient. And more importantly, we want to protect the living donors from losing a kidney that they might otherwise need or unnecessary morbidity associated with the donation process. So we're very, very strict with this. We want the donor to be almost perfectly healthy before they allow to donate. So it's important that you explain the benefits and risks to the donor. And the cardinal rule that we have in doing transplants is that the donor must always be left with a good functioning kidney. Even if they say, I want to give the better kidney to my father or to my child, that should not be the case. No, the donor should always be left with a better functioning kidney. And kidney donation is voluntary, and the donation process should follow legal procedures. So the donor has the right to withdraw at any time, no? Even the day before the surgery, even during the day of the surgery. If the donor hesitates, then we must respect that choice, no? Because this is completely voluntary on the part of the donor. So part of our workup is that we evaluate immunologic risk. So we follow ABO compatibility between recipient and donor. So it's for type O recipients, they can only receive kidneys from a type O donor. For a type A patient, recipient from type A donor or type O donor. So it follows the rules of ABO incompatibility. Although ABO incompatible transplants can actually already be done. No? Worldwide, they're able to do already EBO incompatible transplants. In NKTI, we were able to do one, but it wasn't very successful. But we're planning to start also doing more of EBO incompatible transplants. But for the standard transplantation, remember that it follows also the ABO blood incompatibility rules. And then we also look at the number of mismatches on the HLA tissue typing of the recipient and the donor, but really the matching now does not really matter. No, so even if they're fully matched or they have no match at all, with the use of immunosuppressive agents, we're able to overcome that mismatch and prevent rejection. And then now we have the technology to test, even before you do the transplant, if the recipient has preformed antibodies against the donor. So that means, hindi pa nilalagay yung kidney, alam mo na may antibodies na yung recipient against that donor. So we have tests to detect that in the laboratory. And I think that has contributed a lot to the success of our transplant programs. So these preformed antibodies are obtained by the recipient because they're sensitized. So because the causes of sensitization include multiple blood transfusions, previous pregnancies, previous kidney transplants, and even infections and surgery. So ibig sabihin nito, huwag tayong maging very gung-ho sa pagbibigay ng blood transfusions to our patients with end-stage renal disease on dialysis. So there are ways to improve, to correct the anemia of patients through erythropoietin, through iron supplements. So when you give blood transfusions to a patient, unnecessary, no? Kasi sometimes kung mababa lang, we just transfuse. So that has become a problem for us because when the patients are sensitized, that means they already have antibodies. It makes the transplantation more difficult, and we need to do plasmapheresis and all this desensitization process to be able to find a good donor for that patient. So previously also do third kidney transplants for those recipients na nagkaroon ng failing graft after several years. And it's the most important is that the patient and the donor should have a negative cross match for the transplant to increase that age to 21 years old. And there has to be hospital ethics committee for approval for both living and related and non-related donors. We also have a donor advocate to evaluate to have the PhilHealth Z benefit package for kidney transplant. I included this because I think this is an important program. If you will establish your own kidney transplant facility here in Dlsumc, you need to be So in 2012, when Dr. Enrique Ona was Secretary of the Department of Health, he made sure that kidney transplantation was included in the Z benefit package of PhilHealth. When you say Z benefit package, these are parang very serious diseases na if treated, they're very expensive, but if treated, they have good outcomes for the patient. So, sabi niya noon, ang problema, kung pera ang problema, the PhilHealth will pay 600,000, will give 600,000 for the kidney transplant of standard immunologic risk patients with no serious comorbidity. So may criteria din to because they really want good outcomes. That's why nga yung mga nagiging high immunologic risk patients because of transfusions and everything, bigla ngayon silang na-exclude. Hindi sila maka-avail of this Z benefit package. So with the Z benefit package, this is the highest benefit given by PhilHealth. They will give 600,000 pesos for the surgery of the donor and the recipient. So for no balance billing patients, so these are the indigent patients, that would give support fully, 100%. And for other patients, yung employed, the private patients, that would become now provide 50% support. So that means that if PhilHealth will pay 600,000, the patient can pay up to a maximum of 600,000 pesos as copay. Now, this covers hospitalization and surgery of both the recipient and the donor, all the medications. However, it would, with the benefit, it should also cover for the post-operative complications and 1 month laboratory for the recipient and donor. And this is for living and deceased donor kidney transplants. Hindi lang siya for the living, but also for those who will receive a kidney from the deceased donors. So I talked about immunosuppression, a chance of rejection, even among siblings, even among father and son or child to parent. Kasi half lang, di ba? Your HLA is inherited and blocked, parang isang chromosome siya. So from us, we inherit half from our mother and half from our father. So may chance, ano pa yon? Hindi pa yon full and blocked. So may 25% chance pa na baka fully matched kayo, 25% chance, yung ganon. So only monozygotic twins do not need immunosuppression. Okay, so, but everyone else needs to have immunosuppression to prevent rejection. So when we say immunosuppression, we give induction treatment. These are very strong drugs that we give just before the operation, and a combination of 3 oral immunosuppressive drugs that you need to take lifetime. It's the dose of the drug that may be decreased, but this is something that is maintained by the patient for life. So for the hospitalization, the recipient stays in the hospital for about 9 to 10 days, and the donor 5 to 7 days, depending kung laparoscopic or open. So long-term care, so we do long-term care for both the recipient and the donor. For the recipient, we monitor the renal function, adjust their immunosuppressive medications, and look out for medical complications. Itong mga patients na to, before the transplant, they were already hypertensive, diabetic, Ang dami na nilang medical problems that may not be completely solved by the medicate them, treat them for life. And the donor naman, you function and make sure that wala silang nagde-develop na complications. And if they do, treat those complications after the transplant, especially an overview of our data. I also want to show you our data so you have an idea of our status as a nation in kidney transplantation. So when you look here, okay, on the other hand, for living donation, nandun naman tayo sa may gitna. So for living donation, 4.3 per million population ang data natin compared to other countries in the world. So ang dami natin kailangan gawin dun sa deceased organ donation. But in Asia, we're one of the highest, we have one of the highest rates of living donation. So this is data for the national incidence and prevalence of dialysis patients. So Philippine Renal Disease Registry nag-stop kasi noong 2016. okay, ang pag-collect. But we're working, the DOH is working to resume that renal registry. But as you can see, pataas siya, no? Pataas talaga. And you can only interpolate kung gaano na siya kataas ngayon, no? So, Neil mentioned kanina, 1 person develops chronic kidney disease per hour. So, in every year, siguro mga 20 to 30,000 new dialysis patients undergo dialysis every year. Additional, aside from those who are already diagnosed and are on dialysis. So, chronic kidney disease and its complications in 2019, no, was ranked as the 4th most in the Philippines. And when you look at the national incidence, so there are 3 kinds of renal replacement therapy. There's kidney transplant, hemodialysis, which is the most common, most popular, and peritoneal dialysis is the 3rd. Look at the rate, or the number of people who undergo hemodialysis. Sobrang, halos lahat, nag-hemodialysis. On the other hand, peritoneal dialysis, tsaka kidney transplant, parang nandun lang sila nagko-compete dun sa pinakababa. No, but this is something we do not want. We do not want our patients to remain on hemodialysis for life. But kasi hindi naman yan without any complications. And as you will read from literature, the highest quality of life is really for patients who undergo kidney transplantation. So there are 31, no? From our count, there are 31 accredited kidney transplant centers, but procedures are only actively done in only 21. Sila yung nagsasubmit ng data. So about 500 kidney transplants are done per year, and 90% of these are performed in the national capital region. So I think that's a challenge for transplant centers outside of the NCR, including Dlsumc, no? So ang population are to have their kidney transplants, and we want these people, these patients, to undergo kidney transplants in their own region. Kasi it takes a lot of money, di ba, to live in Metro Manila, to do your work up in the place where you live in. And then, as far as we know, mainly in our center, no, in the National Kidney Transplant Institute, ang transplants, and in 3 other private hospitals. But we're very happy na in the north, they're also starting a robust transplant program, no, in Baguio, in La Union, no, so dumadami na. I think kasabay nun kasi dumadami na rin yung graduates ng transplant surgery, ng urology, transplant anesthesia, and nephrology. So this is just data on our deceased donor versus living kidney donor transplants. This is NKTI data for 12 years. Makikita nyo, hindi talaga nagpo-progress masyado yung deceased organ donation. But pandemic yung dip na makikita nyo doon sa kidney transplant. But our pre-pandemic numbers, census is almost the same as our census now. Let's talk about survival, no? So, our 5-year death sensor graft survival in 5 years is about 95.7%. So that means in 5 years, 95.7% of kidneys are functioning. These are NKTI data. So for our 7-year naman, death sensor graft survival for deceased donor KT, 79%. So the patients resort to deceased organ donation pag wala talaga silang makuha na living donor. However, hindi naman nagkakalayo, no? We have also very good survival data for deceased donor patients. And our 7-year patient survival for deceased donor transplants is 91%. So in 7 years, 91% of them are still alive. When you ask about what about hemodialysis, no? Sa US, wala kasing survival data ang Philippines, but in the United States, in 1 year, PD patients are alive, 88% of them. In hemodialysis, mga 85% of them are still alive. That's 1 year data. But our survival data in NKI for living donor kidney transplants, nasa 99%. So you can see the difference, no? Better survival rates for patients who undergo kidney transplants compared to if they remain on hemodialysis. So this is just living donor data. Dr. Residoro will talk about that later. So ang ratio ng ating living related to non-related is about 1.3:1. And very surprising yung data dun sa... So in other countries, this is what we found out when we look at Asian data. Sa ibang bansa, puro lalaki yung nagdo-donate. Halos lahat, puro babae yung nagdo-donate. They explain na medyo puro male. But in our country, it's usually male. Male to male, male to female. So, medyo mataas ang level ng equality ng females, sa babae dito. Kasi sa kanila daw, parang sa culture nila, yung babae yung parang default na kailangan mag-donate in the family. So, this is just to show you how much the government has spent for renal replacement therapy so that you will have an idea how big the problem is. So, this is data from PhilHealth. So, according to them, for hemodialysis, their payment for 8 years was 94 billion. For hemodialysis, for peritoneal dialysis, 1.5 billion. And for kidney transplant, 1.2 billion. Okay, so you can see the magnitude of the amount of money that our government spends on hemodialysis. And then I'm showing you sa taas, we had a paper done to see kung ano yung best quality of life. So this is a DOH commissioned paper. So nakalagay doon, best quality of life for patients on peritoneal dialysis, followed by preemptive kidney transplant. When you say preemptive kidney transplant, you have stage 5 disease, hindi ka na magda-dialysis. Diretso ka na kidney transplant. And for deceased organ donation, the country has been divided by the DOH into different zones. So, sinong organ procurement organization yung kukuha doon? So, baka i-discuss in later. But Cavite also belongs together with the NCR. So, yung mga referrals for deceased organ donation, yung organ OPO ng NKI, which is HOPE, siya po yung kukuha, siya po yung assigned to do organ procurement if there's a referral from Dlsumc. That's for Region 4. So, we're now going towards multi-organ donation in NKTI. So ngayon po, it's very good news na yung the heart transplant team is nagre-ready na po sila for their own heart transplant. The lung transplant team is also ready to do lung transplant. I think ni-launch po last week yon in Lung Center. In the national waiting list for deceased donor organs for kidney, it's just 224. This is as of November last year. So you can see po, there are tens of thousands of patients undergoing dialysis. And it's very sad na only about 200 patients are on the waiting list for deceased organ donation. Okay, so under universal healthcare, what will happen? So under universal healthcare, we are also encouraging, parang nagiging mandate na rin po, especially in government hospitals, that even their basic and advanced comprehensive centers should already do organ transplantation. And the advocacy and disease donation referrals hanggang sa municipal primary care levels po dapat. So what are advocacies in NKTI? So we want to increase public awareness on organ donation and transplant. We also want, organ donation and transplant to be incorporated into the curriculum of medical schools. We want to establish a donor exchange program for highly sensitized patients. So ito po yung mga pasyente na hindi makahanap ng donor kasi may antibody sila. So we're working towards that. We want also to have sana legislation for an opt-out policy, pero hindi to masyadong kinusto ng mga senator when we wanted 2 years back. Opt-out meaning if you, for example, get involved in a vehicular accident and then you become brain dead, opt out, dapat may sign ka na card when you were alive na ayaw mong mag-donate. So parang ang default, dapat lahat pwedeng mag-donate. Instead of magdo-donate ka lang kung may organ donor card ka, so baliktad. So only if you expressed when you were alive na ayaw mong mag-donate, doon ka lang hindi pwedeng mag-donate. Pero hindi pa masyadong sa kanila yung idea na yon. But this is a policy that's being done legally in certain countries in Europe like Barcelona, in the Catalan region, opt-out sila doon. Kaya ang taas ng rate sila na deceased organ donation. Dito kasi yung pamilya talaga ng pasyente, ng possible donor, ang laki ng influence. And then mandatory referral system sana, especially in all trauma centers and government hospitals for deceased donors. Continued vigilance. No, we're also fighting for continued vigilance against commercial living organ donation. We want to capacitate regional transplant centers. And of course, we want to increase government funding for transplantation beyond the surgery. Ang gusto namin, may financial support din for the patients to be able to take their maintenance medications long term. Okay, so we believe that these are the most important causes why organ transplantation and organ donation have not reached the point na may impact talaga siya to the lives of our ESRD patients. Okay, with that, I'd like to thank you po for your attention, and I'll be able to answer your questions later. Thank you.
Thank you, Dr. Pamugas, for your comprehensive lecture. I hope our audience will be advocates of organ transplantation or organ donation after your enlightening discussion. So we will, again to our audience, please keep your questions until our open forum. We will allot time for your queries. Now let me introduce to you to our second speaker. He also has a master's degree in hospital management from St. Joseph's College Healthcare Executive Society of the Philippines. He is a fellow of the Philippine Urological Association, Philippine Society of Urologic Oncologists, and diplomate of the Philippine Board of Urology. He also received a diploma from the University of Strasbourg for advanced laparoscopy from Strasbourg, France. Let us all welcome Dr. Noel Zachary Residoro.
Morning to everyone, and to Dr. Tan, Dr. General. So I was just may say Coronel. General. Okay, General. I know Neil Bastona very closely because we did his father's kidney transplant a while back. And he's doing good, right, Neil? And also like to thank Dr. Sarah Jane Lampa Garcia for inviting me over to talk to you today. So I'll be talking about the evaluation of the kidney donor. I think the donor is like more important than the recipient, because if there's no donor, there's no kidney transplant. They are angels sent from heaven. Okay. Thank you. So kidney transplantation from a living donor is a treatment of choice for most patients with end-stage renal disease. And to be a kidney donor, you should have the willingness to donate voluntarily, as Dr. Pamugas has said, without any undue pressure. He should have the virtue of altruism, meaning selfless concern for the others. Autonomy, meaning free will to donate. The beneficence and dignity to donate as well. And for most parts of the world, it is illegal to sell your kidneys or buy kidneys for that matter. Especially in the Philippines, it is illegal to do so. However, the recipient may give back to the donors by covering for lost income during evaluation and surgery. It can cover for travel costs, accommodation costs, food costs, and all the laboratory tests that the donor may undergo. It may also cover for lost wages incurred during the procedure and the evaluation. Even cover for childcare if the donor has kids. And of course, cover for surgical operation and the hospitalization. As Dr. Pamugas has said, the benefits and risks of kidney donation should be assessed and the donors counseled, including post-donation follow-up. They should have the adequate time to consider decision to donate or not to donate. And the donor has the right to withdraw from donating at any stage of the evaluation process, and this decision must be respected and kept with the team. Kidney donor should undergo a thorough medical and physical evaluation. This is to ensure that the donor is healthy. This is to minimize perioperative complication. After having an informed consent, that consent should be notarized and must be obtained for donation. They should comply with the registration requirements of HOPE, Human Organ Preservation Office, and the donor should be approved by the Institute's Ethics Committee. As I've said, donors should have a long-term follow-up at regular intervals. So these are the points of particular importance in evaluating the kidney donors. Presence of hematuria, proteinuria, UTI, kidney stones, presence of hypertension and diabetes, the kidney function, cardiovascular risk, weight concerns, previous malignancies, alcohol, smoking, drugs, and other vices, psychiatric history, as well as obstetric history. So if you see a kidney donor on the first visit, you get all these laboratory tests: urinalysis, CBC, PT-PTT, creatinine, electrolytes, fasting blood sugar, thyroid function, and pregnancy test if indicated. You also get virology test to check for hepatitis B and C, chest x-ray, and whole abdominal ultrasound. And once these are all normal, you may proceed with all these tests again. Albumin creatinine ratio, 24-hour urine collection, urine culture and sensitivity, liver function test, calcium, phosphorus, uric acid, albumin, lipid profile. Very important, nuclear GFR scan, we'll discuss that later. ECG for medical clearance, additional virology test for HIV, VDRL for syphilis, CMV, cytomegalovirus, Epstein-Barr virus, and as well as PSA for donors more than 50 years old. You should obtain a psychiatric clearance and medical clearance as needed. So let's go and proceed to nuclear GFR. GFR is, or glomerular filtration rate, is widely accepted as the best overall index of kidney function. Donor GFR should be expressed in ml per minute per 1.73 cubic meters, and GFR of more than 90 ml per minute is acceptable for donation, although some institutes would limit it at 80 ml per minute. A GFR between 60 to 89 ml per minute should be individualized based on transplant acceptable threshold. And a GFR of less than 60 should not donate. So this is a sample of a GFR of one of my patients. As you can see, their function is about similar at 62.9 ml per minute on both sides. But sometimes we see GFR scans that are a little bit with different function. The left side being 62.3 and the right being 48.9 ml per minute. And the difference is around 12%. We place the significant difference at 10%. But in this instance, since the difference is significant, we take the right kidney for this case to leave the better kidney to the donor. The future risk of kidney failure is slightly higher due to donation, but the absolute risk for 15-year follow-up remains relatively low. A donor may lose 50% of its renal mass, but with compensatory hyperfiltration, it would only lead to a net reduction of GFR of 30%, accounting for approximately 25 to 40 ml per minute in the GFR function. Some other pertinent evaluation that we need from the kidney donor: the age should be between 21 to 60 years old. The BMI should be less than 30. They should stop smoking 4 weeks before the donation, and advise them on lifetime abstinence from smoking. You should counsel your donors for a healthy diet, to achieve a healthy body weight, regular exercise, and stop vices. Let's proceed with pre-donation albuminuria. We check the urine of these donors for albuminuria. Increased urinary protein is generally considered a marker of kidney damage. And albuminuria reflects increased permeability of the glomeruli. You see that in glomerular proteinuria. For low molecular weight proteinuria, this reflects decreased tubular reabsorption or tubular proteinuria. That's why we take an early morning urine sample to check for albumin to creatinine ratio. An alternative to this would be protein to creatinine ratio or 24-hour urine protein collection. And if the result of the albumin to creatinine ratio is more than 30, or the protein to creatinine ratio of more than 0.2, or the 24-hour total protein is more than 200 milligrams per day, this would contradict donation. Now let's proceed with hematuria. If you have a donor with hematuria, you should check and identify its causes. So number one would be UTI. You check the urinalysis as well as the urine culture. If it's positive, you treat it accordingly. If there's persistent hematuria after treating the infection, you do imaging in the form of CT scan or an ultrasound, and cystoscopy to check for malignancy or stones. If it's negative, you can do kidney biopsy to check for glomerular pathology. They may see an IgA nephropathy on biopsy. This should not donate since IgA nephropathy is a progressive disease. But for thin basement membrane disease, they may be eligible to donate since progression to ESRD is rare. For kidney stones, a symptomatic potential donor with history of single stone may be suitable for kidney donation. But you have to treat if they have hypercalciuria, if they have hyperuricemia, metabolic acidosis, cystinuria, hyperoxaluria, and UTI. You check all these and treat them accordingly. You get metabolic workup for these donors with history of stones, serum calcium, phosphate, uric acid, creatinine, alkaline phosphatase, urinalysis, urine culture, and 24-hour urine volume, and compare that to 24-hour urine calcium, phosphate, uric acid, oxalate, cysteine, citrate, sodium, and magnesium, and identify the causes of stones. The acceptance of a donor candidate with prior or current kidney stones should be based on an assessment of stone recurrence risk and possible consequences of kidney stones after donation. For blood pressure or hypertensive donors, donor candidates with hypertension that can be controlled to 140 over 90 millimeters mercury with 1 or 2 antihypertensive medication without evidence of target organ damage may still be acceptable for donation. You check for proteinuria, microalbuminuria, left ventricular hypertrophy, and hypertensive nephropathy. These donors is not eligible to donate, just as long as they don't have these target organ damage. Then they should be counseled on intervention to address modifiable risk factors, to decrease their blood pressure by doing healthy diet, smoking cessation, achieve an ideal body weight, and regular exercise. It's because that for every 20 millimeters mercury rise in the systolic blood pressure, this correlates to around 42% risk of ESRD over a median follow-up of 4 to 16 years. Next would be glucose intolerance. First day of visit, we check the fasting blood sugar level. If it's more than 7 millimoles per liter on both tests, then the donor is diabetic and is unacceptable for donation. But if it's between 6.1 to 6.9, we get a 2-hour oral glucose test. If the OGTT result revealed that it's less than 7.8, the level is normal and is acceptable to donate. If it's between 7.8 to 11 millimoles per liter, it's impaired glucose tolerance and is unacceptable to donate. If it's more than 11, the patient is diabetic. For type 2 diabetes, it is the leading cause of ESRD worldwide and accounts for 50% of acquired adult onset ESRD. For type 2 diabetics, but is otherwise healthy, they have 3 times the risk of ESRD over 4 to 16 years follow-up. So they are not allowed to donate. Type 1 diabetics, especially, they are not allowed to. Donate as well. How about for infection? We check this battery of tests for transmission of infection for donors. We test for HIV, hepatitis B, hepatitis C, CMV, EBV, and syphilis. We test HIV, HBV, and HCV within 28 days before donation. If the donor is HIV positive, this contradicts donation. If the donor has HBV positive, this contradicts donation to HBV negative recipients, but may be considered for HBsAg positive recipients. For HCV positive donors, this contradicts donation. But if the donor has EBV or CMV positive, this does not preclude donation, but can be a guide in post-transplant antiviral prophylaxis and monitoring of risk for lymphoproliferative disorder in their kidney recipient. If the donor has syphilis, they may be considered for donation after treatment of the donor candidate before donation. If the donor has TB, donation may be considered after treatment of that active TB infection. For donors with malignancy, an absolute contraindication for donation, melanoma, testicular cancer, renal cell carcinoma, breast cancer, lung cancer, and choriocarcinoma. Donors can still possibly donate if the treated cancer with high probability of cure is more than 5 years, such as colon cancer, non-melanoma skin cancer, CIS of the cervix or vulva. So next on the list for donor tests or evaluation is the CT angiogram. A CT angiogram would identify the vessels or the number of vessels in each kidney, renal artery, renal vein, as well as the ureters. So this slide shows us single artery on both kidneys, on your right side, on my right side, and on the left side, single ureter on both sides. This also shows us a single renal vein. The left renal vein is much longer as compared to the right renal vein. And therefore, we prioritize to donate the left side to have a longer venous pedicle. And if we do the left side, we can do it through laparoscopic approach. On the right side, because it's shorter, we often do open donor nephrectomy on the right side. This in order to get a caval cuff or a portion of the vena cava using a special clamp, a C-clamp. After clamping, we suture back the IVC using Prolene. So sometimes you get an angiogram with these kinds of kidneys with 3 arteries on both sides. So this is the dilemma for me and for the transplant surgeon as well as the nephrologist. But still we lean towards getting the left side. The left side is on that side. Since we'll have a longer venous pedicle. As you can see, the accessory artery, the artery on top of the left kidney, supplies the upper bowl. Sometimes the transplant surgeon would opt not to transplant that anymore. 2 of those, so they're pretty large. The transplant surgeon can easily transplant those arteries. Right, Louis? You can do those kinds of kidneys. So this is a list of the absolute contraindications of renal disease, recurrent stones or bilateral stones, cardiovascular disease, moderate to severe pulmonary disease, diabetes, and impaired glucose tolerance, hypertension of more than 140/90, any form of malignancy as I have discussed, neurological disease. There are also relative contraindication to donation, more than 60 years old, just as long as the patient is, the donor is healthy, obesity of more than 30, very recent pregnancy, but we advise donating after 6 months from delivery, active TB infection, single prior episode of stones, renal cyst, more than 2 cysts per kidney, and history of gestational diabetes. So how do we decide on what side to donate? Living donors should be left with a good functioning kidney. Instead, we can still opt to donate the better functioning kidney if both kidneys have more than 90 ml per minute combined function. The left side is prioritized in laparoscopic donor due to a longer venous pedicle, and the kidney with single vessels and is less complicated. So laparoscopic approach is the standard of care in donor nephrectomy. It may be transperitoneal or retroperitoneal, but in the Philippines, it's mostly done transperitoneal. We leave open donor nephrectomy on the right side, as I've said, since we want to hide. And if with extensive abdominal surgery, we cannot do transperitoneal laparoscopic approach, we do open. And of course, based on the experience of the surgeon. The outcomes between laparoscopy and open is similar and comparable. However, lap has reduced analgesic use, earlier return to work and normal activity, has faster hospital stay, better cosmesis, and minimal blood loss. So if we do open donor nephrectomy, the patient is on a side-lying lumbotomy incision, much like this one, and we do it between 11th and 12th rib, mostly on the right side. For laparoscopic donor nephrectomy, these are the critical steps: trocar placement, mobilization of the kidney, identifying the hilar vessels, extraction of the kidney on the site prepared, harvesting, and wound closure. So this is the position of the patient during laparoscopic donor nephrectomy, side lying. The patient is near the surgeon. This is the trocar placement for laparoscopic donor nephrectomy. And this slide shows us where we extract the kidney from. We do a low fan and steel incision, much like the bikini cut in a cesarean section. So this is mobilization of the colon, which would then expose the kidney on the left side. We identify the ureter, this is the ureter, and then trace that superiorly to expose the hilar vessels, the renal artery, and then the renal vein. And then artery, we clip it, two hemlock pliers plus a titanium clip to ensure that there is no aortic leak. And then the vein, we clip it twice with hemlock clips. I think this is my last slide. Without the organ donor, there is no story, no hope, no transplant. But when there's an organ donor, life springs from death, sorrow turns to hope, and a terrible loss becomes a gift. Thank you very much for your kind attention.
Thank you for the remarkable discussion, Dr. Residoro. So, for our last speaker, he is a graduate of Doctor of Medicine from the University of Santo Tomas. He took his general surgery residency in Batangas. He took his transplant and vascular access surgery fellowship from the NKTI, where he was awarded as the most outstanding vascular fellow. He is a fellow of the Philippine College of Surgeons, Philippine Society of General Surgeons, and the Philippine Society of Transplant Surgeons. Currently, he is the Vice President of the Philippine Society of General Surgeons in Southern Tagalog Chapter, and the current Chairman of the Renal Care and Transplant Specialty Center and Organ Donation Committee in the Batangas Medical Center. Our last speaker, Dr. Mark Louis Lante.